has more than 2 decades of experience in teaching both undergraduates and postgraduates. He has faced two successful audits, US FDA and Canadian, and is a principal investigator in more than 75 clinical trials, fellow and life members to many prestigious organizations, has several national and international publications, and has deliberations, and his presence is felt as faculty in most of the national forums and conferences. Being a governing council member of RSDDI and ACP Indian chapter, I hand over to you, sir, for taking or showing us the light which path to follow in this conflicting hypertensive guidelines.
Thank you, sir. Thank you for the kind introduction. And I sincerely thank Professor N. Rai, sir, Ketan, sir, whom I admire a lot, NK Singh, sir, and Virmani, sir. And of course, it's my privilege to share the dais with Muruganathan, sir, which I consider him as a guru in many aspects. And this task is given by Virmani, sir, to me to talk about the conflicting guidelines, which one to follow. Luckily, it didn't mention how many guidelines I should choose. So I've chosen these four: 2020 International Society of Hypertension Global Guidelines, 2018 ESS and ESH, 2017 ACC AHA, and of course our own Indian guidelines, which is called Indian Guidelines on Hypertension 4, published in October 2019. So I have divided the topic into these 7 sections where it deals with the definition, classification of hypertension, measurement of blood pressure, diagnosis, evaluation, and hypertension-associated target organ damage, non-pharmacological interventions, and drug therapy of hypertension. And after each section, I will try to give the concise opinion about what is the definition. For example, in the definition group, I'll tell what is the definition of these two so that we get less confused. I'm sure I'll not be able to confuse you more because there are n number of guidelines in the books. So let us move on to the definition and classification of hypertension. The 2017 ACC AHA says BP should be categorized to normal, elevated, stage 1 and 2. This was in 2017 ACC AHA. Stage 1 says 130 to 139 and 80 to 89 is the diastolic. So 140/90 if you cross, then you're in stage 2. That is in 2017 ACC AHA. 2018 ESH ESC says if you look at that 140/90, you're still in the grade 1. So that is the difference between that. So more than 140/90 is defined office BP. Muruganathan sir was very elegantly alluded so far about the office BP part and the home BP monitoring. I'll be talking about the guidelines perception about these two as well. So this is the 2018 ESC ESH guidelines. 2020 ISH guidelines, which seems to be more practical, where hypertension is diagnosed when the office or clinic BP more than 140/90 following repeated examination. That's very important. And they have classified into high normal, grade 1 and grade 2. Again, 140/90 and 160/100 is grade 2. This is based on the office BP. Now, criteria for ambulatory BP and home BP, they're slightly different. And this is what Muruganathan sir is alluding all this while. Office BP, you say more than 140/90, and look at the home BP, it is 135/85. So this is more accurate, more convenient, easiest method for us to diagnose. So all of us should try to push this HBPM and try to look for, of course, ABPM guidelines are different. 24 hours, daytime, nighttime, they have divided again into sub-classification. So office BP and home BP, there is a definitive difference to diagnose. And this is the latest 2020 International Society of Hypertension guidelines. Now let us look at our own guidelines of Indian guidelines, which is 2019, 140/90. But they've again got a high normal and they've divided into stage 1, 2, 3 based on 140/90 and 160/100. And beyond that would be your stage 3. And isolated systolic hypertension, there are two gradings if you closely observe here, 140 to 160 and more than 160, diastolic being less than 90. So they've got this extra classification, which is not there in any other classifications. This staging is similar to ESC, ESH guidelines. So 140/90 is basically all this. So to summarize all these guidelines, ACC, AHA, stage 1 means you are between 130 to 139, 80 to 89. That means 140/90. You don't cross that, that's stage 1. Whereas in ESH, ISH, and Indian guidelines, it is 140 to 159 and 90 to 99. This I'm talking about stage 1. This is a comparison between the guidelines. So this is the essence when it comes to the classification between these 4 guidelines. So let us move on to the next section, measurement. Now, The level of evidence for diagnosis managing high BP is the proper methods is to accurately document the BP, that is ACCHA clearly talks about the cuff size and the arm circumference and the cuff size. We'll not get into these details, but Muruganathan sir rightly alluded just prior to this. Out of office or self-monitoring of BP, that is again home BP monitoring. You can see this correlation. The out of office BP measurements are recommended to confirm this diagnosis of hypertension and for titration of BP medications in conjunction with the telehealth. For example, is very, very important at the current pandemic situation of medicine teleconsultation. So look at the corresponding values of home BP, daytime ABPM, nighttime ABPM, and 24 ABPM. So these are all the corresponding values which matches, which is definitely home BP is 135/85, where the diagnosis cutoff is there, and 140/90 at the clinic. And you can clearly see the home BP and the daytime ABPM matches. 135/85 is the cutoff. So that's the best part about the home BP. And this is one of the things, comparison between ABPM and home BP monitoring. Advantages: simpler, easier, economical, widely can be used. Of course, disadvantages are there in the home BP, that no nocturnal readings, as Muruganathan sir was telling. There are recent improvements in this where we will definitely get in future to measure this nocturnal BP. But definitely cheaper, widely available, and patient engagement can be better, adherence can be better, thus less complications to the patients. So comparison, whether with respect to this, the guidelines, ACC, ESH, ESE, all these advocate the use of out of office BP. It is not your clinic BP, it is out of office BP for confirmation of diagnosis. Very clear message. And ESH, ESE guidelines have also clearly outlined the benefits of ambulatory BP and home blood pressure monitoring. This is what just Dr. Muruganathan sir was talking about. Very, very clear. It is out of office BP measurements are required to diagnose, and very important point to note. Diagnosis, again, I brought in another one for adding on to some more confusion. That's a Canadian guidelines, where it talks about elevated BP once crossed more than 180. Okay. Elevated BP, when you cross more than 180, 110, it's clearly diagnosed. But when it's not 180, 110, it's more than 130, 85, 135, 85, and with diabetes, the diagnosis lowers down to 130, 80. Without diabetes, it is 130, 85. So this is how you proceed. They recommend ABPM or home BP series of measurements. You can very clearly see even the Canadian guidelines emphasize on the home BP monitoring or the ABPM before you initiate drug therapy and to rule out the white coat hypertension. Now let us look at screening and diagnosis of hypertension with a perception of ESH and ESC, optimal, normal, high normal, and hypertension. We'll not talk about these two. We'll talk about the high normal BP, 130 to 140, less than 140, and 85 to 89. Always rule out the masked hypertension in this segment, and that is where this high normal bifurcation classification helps us in the clinical practice. And repeat this at least annually, they say, but I would say every 3 months, and then you need to diagnose and work up when you suspect the masked hypertension. The out of office BP again comes into picture. You can very clearly see the ABPM or the home BP monitoring. And when somebody has got a definitive diagnosis of hypertension more than 140/90, the repeated visits office BP, you can diagnose, or out of office BP, again, you can diagnose and indicate whichever is required. So this is very clear. ABPM or how home BP monitoring is the emphasis for all these organizations' guidelines. Now, the recommendations for office blood pressure, that is your clinic blood pressure, normal, high normal, and hypertension. Now, what do you do when it's high normal? This is the ambiguous readings, 130 to 139, 85 to 89. You take 2 or more readings and use the average of second and third reading. And if it comes out more than 130/85, remeasure again in 2 to 3 different office visits in a different days, not on the same time. And repeated office BP more than 140/90 average indicates hypertension, and you go about further. And based on the ABPM or ambulatory BP, you can again talk about the home BP monitoring more than 135/85 or ambulatory BP more than 130/80 would push somebody into the diagnosis of hypertension. So this is how you proceed, and this is the recommendation of ISH. Again, according to the office BP, this is how you plan the 130 to 160 and 85 to 99. This is a category where you confirm out of office BP blood pressure measurement, because there is a high possibility of white coat or masked hypertension in these. So you confirm them, repeated office visits or out of office BP, and then go about. When it is less than 130/85, you reassure within 3 years and every 1 year if there are other risk factors. 160, 100 and beyond, you are very much confirmed. Now let us talk about the Indian guidelines. The guidelines for diagnosis by different methods. Again, we have emphasized on home BP monitoring more than 130/85. It matches with our guidelines, other guidelines. 140/90 is the cutoff, which is clear cut beyond 140/90 at office BP. And 130/85, you can again see these two match the daytime ambulatory BP and the home BP monitoring beyond 130/85 classifies somebody into hypertension. Now let us move on. After you diagnosed, what is you need to evaluate? What does the guidelines talk about? The evaluation part. The ACC/AHA clearly talks about the routine blood tests. I'm sure this August gathering do not require any expansion of these, but definitely they talk about optional testing of echo, uric acid, urine albumin to creatinine ratio. This is ACC/AHA. But what does ISH say? ISH include these in this routine test. And also they talk about history and physical examination, clinical examination to rule out the end organ damages and look for some subtle signs, symptoms. And additional tests, they say organ damage, particularly in secondary hypertension and if you suspect in a given patient. This is ISH. And what does ESC, ESH talk about? They include everything, including the ECG and the urine analysis, which includes albumin creatinine ratio. Only the ESC, the other guidelines differed when they talk about this as additional guidelines. So all guidelines recommend routine lab tests. So there is no differences in these guidelines when it comes to the estimation or evaluation of blood glucose, lipids, thyroid, uric acid, creatinine, electrolytes, calcium, and ECG with hypertension. This is a common across all the guidelines. They say you need to evaluate through this. Now let us look at hypertension associated target organ damage and the CV risk assessment. We know the 10-year cardiovascular risk categories, very high risk, moderate, and low. Now, the very high risk, what I want to highlight is you can look at this diabetes mellitus with the target organ damage. Most of our patients fall into this category just by this default with the target organ damage and presence of diabetes. Of course, established CVD, TIA, strokes, CAD, stenting, all this falls into very high risk. And high risk, again, you can see most other people with diabetes fall into this high risk category. So blindly diabetes can be treated as a high risk category whenever you treat hypertension as a comorbid condition along with diabetes. Now hypertension LVH is another very good marker, especially in the case of masked hypertension where there is LVH on the echo or ECG, but the BP is normal at the office level. So you need to suspect masked hypertension with this very good marker to evaluate further. Now let us look at classification of hypertension stages according to the BP levels. You can see here the various BP levels is based on the grading, I normal, grade 1, 2, and grade 3, with other risk factors like hypertension mediated end organ damages or diabetes. So again, I'm trying to highlight this portion. It's called stage 2 when it's called hypertensive disease staging, which is asymptomatic disease, basically diabetes without organ damage. So just mere presence of diabetes or CKD grade 3 or HMOD, other presence, moderate high risk with a BP of say 140/90. So when the BP crosses more than 140/90 and this with diabetes, you can see it pushes into a high risk category. So very important, this is the set of group of patients which we treat day in and day out, and we should not neglect bringing down BP. Remember, bringing down BP gives you more beneficial effects with mortality and morbidity benefits compared to bringing down the HbA1c. All of us forget in our busy practice, it's hypertension which gives you more benefits to your patients when it comes to the mortality and morbidity benefits. Now, the recommendations, this is the for assessment of hypertension mediated organ damage. The arrow marks clearly indicate this is a must for all hypertensive patients. That is ECG, the measurement of serum creatinine and EGFR, and urine albumin creatinine ratio, and a funduscopy. It's very, very important. 4. These other ones are all optional, like your ultrasound, carotid Dopplers, echo, etc., including MRI, cognitive dysfunctions, evaluations, all that are optional. But these 4 is a must for all patients at baseline when they are diagnosed with a hypertension. So coming to the risk assessment, the overall comparison, what I've done is the ESC, ESH guidelines have extensively classified these stages according to their BP levels, presence of risk factors, the end organ damages or the comorbidities, and also they have targeted investigations to confirm and rule out the presence of target organ damage. So very important, we need to evaluate. The second point here is very important, and across these bodies have clearly told us that this is what we need to evaluate. Now, let us look at the hypertension associated target organ damage and the CV risk factor. So this is a very summing up of a slide where initiation of BP lowering treatment apart from lifestyle and medications, when to start. And this is ESH, ESC guideline. You can very clearly see high normal, grade 1, grade 2, 3. Let us look at grade 1, 140 to 159, 90 to 99. The lifestyle is the basic one, which we tend to spend less time in our busy practice. Again, problem with most of us because of the busy schedule. And immediate drug treatment, high or very high risk. That means if it's a diabetes, you'll obviously fall into high risk category at a grade 1 hypertension itself, and we attracts immediate therapy. Of course, grade 2 and grade 3, there is no doubt that we have to, with lifestyle modification, initiate the drug therapy at the earliest. Now, let us look at the office BP treatment targets, general recommendations in any hypertensive. This is across the bodies. I've taken this, and you can see level 1, class 1, level A recommendations. You should achieve BP of 140/90, and once you achieve, you can fix a target of 130/80. And in elderly, more than 65 years, that means, but in Indian guidelines, it is more than 55 years. And in older patients, more than 65 years, it is recommended that systolic BP you target between 130 to 140. If it is less than 65 years, you can target to 120 to 130. That means 130/80 seems to be the great idea of number, is systolic and diastolic BP in most of our patients. So very important learning message, and class 1 level A evidence of all these 3 points. Please remember, in office BP, that is in our clinic BP, this is what we should aim at in our busy practice. Let us look at the summary of office BP thresholds for treatment. ESH, ESC guidelines have compared with the diabetes, CKD, CVD, or a stroke. This is the additional risk factors. So if you see, they've classified into 2 groups, 18 to 65, 65 to 79. Of course, more than 80, we don't see much, but these are the 2 groups. And if you look at the readings, it's more than 140/90. This is the office BP thresholds for treatment in all these, whether it is diabetes, CKD, and CVD. And this slide talks about the target ranges in the office BP control, except in CKD. You can see where the systolic BP is 130 to 140 if tolerated well. All others you target to 130 or lower, of course not below 120, very clear. And the diastolic BP 80 to 70. So this is what you should remember. 130/80, like we discussed previously also, this is the targets recommended at your clinic level, your hospital level, 130/80. Most of the comorbid conditions like strokes, CVD, or diabetes, except CKD. Of course, it's very difficult to control BP. We know that for other reasons. And this is across the age group 18 to 80 years. So very simple, very easy to remember. There is no confusion across the groups. Now let us look at the Indian guidelines. Indian guidelines say stage 1, that is 140/90. Repeat readings should be taken within 2 to 3 weeks following institution of lifestyle modification in the 2 to 3 weeks, or say 1 month. And pharmacotherapy should be started after 1 month of this lifestyle modification, which most of our patients do not follow. And eventually they will go on to medications. And BP should be recorded in both arms, in lying and standing before initiation of pharmacotherapy. And stage 2 or 3 hypertension, a shorter waiting period is required. That is less than a month, you initiate treatment when you see stage 3 or 2. And in those who have evidence of end organ damage or target organ damage, pharmacotherapy should be started immediately or early. But remember, the target BP, again, our Indian guidelines talk about 130/80, like the other guidelines, but the age is 60 years below. And more than 60 years, you can target 132, you have a little bit relaxation, 130 to 140, and 80 to 90. The target should never be below 120/70, like any other guidelines. And let us look at the treatment options now. The ISH talks about grade 1. When you're there, you start drug treatment with high risk or all other persistent BP elevations after 3 to 6 months. In grade 2, you start drug therapy with lifestyle. And what are the drugs? They are divided into non-blacks and blacks. We'll not get into these details, but the left side is most important, which most of us neglect, about the lifestyle interventions, which we fail to do in most of our patients: the smoking, exercise, weight loss, salt reductions, and alcohol intake, and healthy diet and exercise. So let us compare now. All the guidelines recommend 3 months on regular BP monitoring and lifestyle modifications to lower the BP. And both ESH, and Indian guidelines recommend a target BP of 130/80 in people below 60 years, and 130 to 140 and 80 to 90 in people above 60 years, and do not touch less than 120/70. Now, finally, non-pharmacological and pharmacological interventions. Again, we always spend less time in our routine practice, and here also, because of want of time, I have to rush through these slides. And very important, weight loss, healthy diet, sodium retention, potassium supplementation. All these, you look at the recommendation levels, 1 and A, all these have got positive, statistically significant benefits: increased physical activity, reduced consumption of alcohol. All these have got this very, very important benefits, and which we fail to implement in our patients because the onus is also partially on us because we don't spend enough time to tell about the good effects of weight loss. Now look at this slide. Weight loss of less than, 1 kg, we can bring down up to 1 mm of mercury. And this is the impact you can have over a period of time. Weight loss, 5 millimeters of mercury reduction. And remember, just by 10 millimeters of reduction, you are reducing 50% of risk of mortality, CV mortality and morbidity. So 5 millimeters without any drug, just by weight loss, if you motivate somebody, you can have this. And DASH dietary pattern, again, 11 millimeters impact. Reduced intake of dietary sodium to less than 1.5 grams, especially in our continent, 5 to 6 millimeters it can impact, like our papad, pickle. And enhanced intake of dietary potassium, that is fruits and vegetables, can bring down 4 to 5 millimeters. And yesterday, our NK Singhs are very elegantly alluded about exercise. Even a small bout of intense exercise can give rise to so many physiological benefits. Even diabetes is showed us. And this is what the relevance of aerobic exercise, 90 to 150 minutes per week, that means about 20 to 30 minutes per day itself will give them 5 to 8 millimeters reduction of mercury. Again, the onus is on us that we do not implement, we do not emphasize the importance of this to our patients. And alcohol consumption reduction less than 2 drinks. We will not get into the details, but it can definitely have a minus 4 mm. And again, I want to show this, that binge drinking definitely has not got any correlation. They say it's class 3 recommendation, but 2 drinks is definitely allowed. But that's a debatable subject. We will not go into what is the units per week for men, women, etc. And look at this highlighted area. The BMI maintaining 20 to 25 will have less risk to develop hypertension itself. There are a lot of papers on that. Waist circumference 94 and 80 respectively for men and women. If you maintain that, you are less evident. And this is a 1 and A, level A and class 1 recommendation for you to maintain this. So all guidelines emphasize on lifestyle modification, weight loss, physical activity, smoking and drinking limitations, salt restrictions, consumption of fruits and vegetables to reduce blood pressure. So there is no ambiguity across the guidelines. Finally, the drug therapy. This is the ESC guidelines. They are now talking about initial combination, and we are experts in FDCs, the fixed drug combinations in India. We've been using from ages, and this is what the recommendation is: 1 pill with a 2 drug combination for, except for grade 1 hypertension with no other comorbidities. Otherwise, they recommend now straight away go to double drug, and that is ACE, ARB, CCB or diuretics. And step 2, you add on a diuretic or do this permutation combination again. And in stage 3 or step 3, you do the resistant hypertension where the MRSI spironolactone is added, and beta blockers are only now limited to the concised or specific indications like heart failure or post angina, post MI, etc. This is hypertension with diabetes. The same. There's no changes. Literally, triple drug combinations are now encouraged. Double drug combinations are encouraged. That is the message, just to have adherence with our patients. And what about the Indian guidelines? Indian guidelines talk about stepwise management with a monotherapy in younger age group. The younger age group here they've taken is 55 years and less, and 55 and above is A. A stands for your ACE or ARBs. You can see here the definition. And CRD, calcium or diuretic, calcium channel blockers are diuretics. And step 2, 3, 4, and 5 step is there where alpha blocker or beta blockers are seen. And step 4 is something like a resistant hypertension. So this is what the permutation combinations you can choose for your patients. Of course, it has to be individualized. The guidelines are just to guide and to give us some overall bird's eye view picture for us to diagnose and treat. So what do you do after treatment? You have to follow up. Now, what is the follow-up period? The various guidelines talk about initially 1 month if there's somebody is a grade 1 and above, and then look for side effects and then follow up. Change the permutations combination, choose the combination which has got a synergism like a CCB and a diuretic to counter the adverse events of each other molecules. And that's how you need to look at. And if somebody is mild, then every 3 months you can follow up titrate. And this is again AACC, AHA guidelines, which track down the stage 1, stage 2, etc. based on the ACVD risk, and then go into the 1 month follow up. And if the goal is achieved, then you up titrate, down titrate, change the molecules. Of course, don't combine ACE and ARBs together. And these kind, they are very clearly emphasized. Now, finally, the choice of initial medication, the initiation of antihypertensive drug therapy, the first line agents now include thiazide diuretics, CCBs, ACE or ARBs. Beta blockers are out of this list now. And initiation, always the 2 first line agents of different classes has to be chosen, either as separate agents or in a FDC, and is recommended in adults with stage 2 hypertension and an average BP of more than 22 and BP more than 20/10 above their respective target of a given patient, this is how you choose. And to finally compare all major guidelines, recommend the use of ACE, ARB, CCB, or diuretics for the initial treatment, and FTCs are encouraged, and they combine ACE or ARB with CCB or diuretics. And finally, to summarize, out-of-office BP measurements are encouraged, ABPM or home BP to diagnose. Lower blood pressure targets are set for elderly population high-risk group, and simplified drug treatments like ACE, ARBs or CCB diuretics do not complicate regimens, do not give individual drugs, try to make FDCs so that the adherence and compliance is better with the patients, and target blood pressure thresholds for treated patients to help define them the recommended blood pressure targets and lower safety boundaries so that the treated patients are benefited. And you always stood based on their age and other comorbidities. And even after starting pharmacological therapy, please emphasize on the lifestyle changes every visit when they come. And that is it from me. And I'll leave with this controversial slide where the lady says about the blood is boiling, about this guy who says drug companies, and here it says blood pressure guidelines are eased. So thank you very much for the patient hearing. I'm again thankful to the organizers, Virmani sir, for giving me this task.
Thank you, Dr. Sreenivas, for an excellent talk. Just one last question before we go to the next session. Which calcium channel blocker has anti-proteinuric effects?
In the guidelines, they have not mentioned with respect to that, sir. So
no, your
talking
experience, your experience, your wisdom.
Okay, I use amlodipine as the most commonest one in my practice because that is the best one to control BP. The first one is to control BP, then the pleiotropic effects.
Dr. Narsingh Verma, are you there?
See, verapamil, Virmani, verapamil.
Yes, Dr. Muruganathan.
Yes, sir.
Verapamil and diltiazem is supposed to be non-hydroproteic CCBs are good for proteinuria. And of course, the nephrologists use cilindapine. And now beridapine and acetapine also they say it is good for proteinuria. So as Sreenivasmurthy says, the amlodipine or calcium channel blocker is very good in reducing blood pressure. By reducing blood pressure, the proteinuria can be reduced indirectly. But directly, if you ask me a question, there is a proteinuria, the choice by the nephrologist is cilindapine, acetapine, beridapine. And of course, theoretically, verapamil and diltiazem also can be used in the proteinuria hypertensive patient.
ACE inhibitor and a CCB combination will be better choice for such patients.
Of course, of course.
There
was only one question. Yeah, question was on which CCB reduces.
Okay.
Anyway, thank you, wonderful for the three speakers. I'm thankful to Dr. Narsingh Verma, Dr. Muruganathan.